Hello, I'm going to give you a background to the SINAPPS2 trial, and if you want to find out more information, then our website has the links to all of the papers that I'm going to refer to. So the SINAPPS2 trial is the study of immune therapy in antibody-positive psychosis, and it really feeds on from the understanding in neurology and the discovery of antibodies causing presentations of encephalitis, really, that has been transformed neurological treatments over the last 20 years or so, since the discovery of the first antibody that directly was linked to presentations of encephalitis back in the early 2000s, the antibodies against the voltage-gated potassium channel complex. And this really was a game changer, because although antibodies have been associated with encephalitis and sort of brain pathology for many decades, this was the first antibody that was considered directly causative to the underlying neurological disorder, and whereby removing the antibody actually treated the clinical presentation. So all of a sudden it uncovered antibodies that you could test for that actually made a difference to patients if you identified them, and you gave different sorts of treatments that actually removed antibodies from the brain, from the body, and improved outcomes for many patients. So these are just the partial list of the antibodies that have been recognised in association with encephalitis. There are many more, but these are the ones that particularly that we test for in the SINAPPS2 study. And the main one really is the NMDA receptor antibody, and that's the one that's been most studied and is best understood in association with encephalitis in particular. So the reason why it was such a game changer is because these antibodies have been shown to be against neuronal cell surface targets. So they stick to the surface of the neuron. They cause the clinical presentation as a direct result of that disturbance of the receptor, and they can be removed using sort of generic treatments such as flushing the antibodies out using something like plasma exchange, or competing with healthy antibodies using intravenous immunoglobulins, for instance. And stopping the body producing further antibodies is also then therapeutic for the clinical syndrome. We test for the antibodies using very, both sensitive and specific assays, these human embryonic kidney cell-based assays at the bottom there. So we grow cells that express just the particular antigen that we're interested in. So for instance, the NMDA receptor. And then you put the patient sample across those cells, and then if you have the sample sticking to the cell, you can be pretty sure that it's an antibody against that particular target and nothing else. So it's a specific assay that we use to diagnose these disorders. The disorder that's now pretty well described and recognised around the world in neurology settings is NMDA receptor antibody encephalitis. It was first described in young women, but actually it's much broader now, from babies to older people. And it was initially in association with ovarian teratomas, benign tumours of the ovary that express the NMDA receptor and cause the body to produce antibodies against it, which then get into the brain and cause an encephalitis syndrome. But again, we now see teratomas in a minority of patients presenting with this disorder. But of interest to psychiatrists in particular is the clinical syndrome, because whilst it's a rapidly progressing, life-threatening illness that, if left undiagnosed can cause, a significant mortality rate or severe morbidity in people that do survive it. But the initial presentation is to psychiatrists, and it's with psychiatric symptoms that we would recognise as psychosis, in particular, behavioural disturbance, agitation, sort of acute personality change. Often people are severely mentally unwell, such that they'll be often on inpatient units. So most people present to psychiatrists initially, and then it's over the course of 2 or 3 weeks that the illness progresses into a sort of the life-threatening autonomic disturbance and loss of consciousness, that you need to be able to pick up this disorder in that initial week or two, really, to be able to improve outcomes. And these are the treatment response data for those patients with NMDA receptor encephalitis, to show that giving immune therapy is effective in these patients. So IT here is immunotherapy, and the y-axis is the modified Rankin scale, which is a very compressed scale of functioning. So these data show that giving immunotherapy in less than about 6 weeks or so really has a dramatic difference in eventual functional outcome. So the difference between requiring ongoing institutional care and being back at home and symptom-free, for instance. So although these are observational data, they're not controlled in any way, they have been enough to transform care for this disorder. So there is no equipoise amongst neurologists. If this disorder is diagnosed or suspected, then immune treatments will be given rapidly and aggressively. So we wanted to answer the question as to whether these antibodies could also be responsible for some cases of psychosis of people under psychiatric services who don't progress to the full syndrome of encephalitis, but who may require treating in a different way. So we started by testing people right at the beginning of a first episode of psychosis with less than 6 weeks history of illness, and we screened 228 patients for antibodies and found about 3% had NMDA receptor antibodies, and a few had other antibodies of interest as well. Although interestingly, a few control subjects also had some antibodies. When you combine our case control data with other studies that have been done to look for NMDA receptor antibodies in psychosis, you get a very mixed picture, with some studies showing a very high rate of antibodies in patients versus controls, and some showing no difference at all. In trying to understand the marked variability in these studies, we analysed the different methods used for testing antibodies and found a marked difference in the studies that used a live cell-based assay and those that used a fixed cell-based assay. A live cell-based assay has the cell surface intact, and is the one that we use through our PPIP2 study, and is available through recruiting through research only. The fixed cell-based assay is much more widely available, but the process of fixing the cell, we think, denatures the receptor, and you have a marked loss of sensitivity in being able to detect antibodies, particularly in psychosis samples, so that the studies that used the fixed cell-based assay did not find any difference between patients and controls in those studies. So we think it's really important for being able to identify antibodies in patients with psychosis that the live cell-based assay is used. Okay, so the most important question is whether these antibodies are actually pathogenic in people with psychosis, and whether they respond to treatment with immunotherapy in the same way as people with encephalitis, and that's the purpose of the SINAPPS2 trial. We already have some initial data that people with psychosis do indeed respond to immune therapy, and part of this is from our SINAPPS2 feasibility study, which was set up to answer the question as to whether it's possible to deliver these very different kinds of treatments to people with acute psychosis. So we recruited 10 people with one or other antibody that you can see there, and we set the study up to see whether we could deliver the trial treatments, which are intravenous immunoglobulins, although as you'll see there, half the patients actually were given plasma exchange because this was an open label treatment study, and neurologists could give whichever treatments they thought were best indicated. We measured psychosis symptom scores before and 6 weeks after giving the immune therapy, and as you'll see here, particularly the patients with the NMDA receptor antibodies made a dramatic response in terms of their psychosis following immune therapy, with the psychosis pretty much disappearing in many cases after treatment with immune therapy. So whilst we have some early indications that these treatments are indeed warranted for people with psychosis and antibodies, we need to show this in a more definitive way. We need to do the double-blind placebo-controlled trial, and that is what SINAPPS2 is. It's a trial of intravenous immunoglobulins and rituximab in patients with psychosis and one or other neuronal cell surface antibody. Our inclusion and exclusion criteria have hopefully been made as simple as possible to allow as many people as possible to take part. Our age limits are at the moment 16 to 60, but after COVID the upper age limit will increase to 70. People have to have acute psychosis symptoms. They don't have to have any particular ICD-10 diagnosis, but they have to have a psychotic disorder of some kind, which means they have to have symptoms for at least the last 2 weeks. The episode cannot be longer than 2 years, but it can be a relapse, so people can have had a long history of illness. If they were then well for at least 6 months before this current episode of illness, they would still be eligible. And they have to have an antibody either in the serum or the CSF. The only exclusion criteria really are exclusions for being given rituximab, which you can see there, or coexisting severe neurological disease, and that includes encephalitis. So if in the opinion of the recruiting neurologist, the patient has autoimmune encephalitis rather than psychosis, then they would be excluded. Psychiatric treatment can continue as required in exactly the same way as previously. We just ask that the treating psychiatric team keep in touch with us and let us know what treatments are being given. The actual trial treatments are infusions that are given initially over 2 to 4 days. Those are quite long days. IVIG has to be given very slowly because it's quite a viscous liquid. And then a month later, the participant returns for infusions with rituximab. So those are given 2 infusions 14 days apart. So here's the flow chart for the trial, and you'll see that whilst we need to randomize 70 people into the treatment, to get to that point we need to screen several thousand people with acute psychosis through the PPIP2 study, and that's really where we need everyone's help across the country. Our outcome measure, our primary outcome measure, is time to sustained remission of psychosis symptoms over 6 months. So psychosis going away and staying away for a sustained period of time. And we will follow people up for between 12 and 18 months to monitor that. That's the end of the background set of slides. There's a second short talk on the practical details of how to recruit to PPIP, which I'd recommend you go on to next. Thanks.